Okay, well, I'd first like to thank the Marseille Society for inviting me to give this talk for the Marseille website. I also need to start with some declarations of interest. I chaired the NICE guideline on antenatal and postnatal mental health update, CG 192, and much of my talk is based on those NICE guidelines. I'm also the National Clinical Advisor currently for the NHS England Access and Waiting Time Perinatal Mental Health Programme. And I have grants from the National Institute for Health Research, NIHR in England, both a research professorship in maternal mental health and also grants on perinatal mental health. I don't have time today to review the epidemiology of the conditions that might need treatment with antidepressants in pregnancy, but I do want to mention that that epidemiology is reviewed both in the NICE update and also in a slightly briefer form in the Lancet series that was published last year in November. We published 3 papers as part of that Lancet series. One was on non-psychotic mental disorders in the perinatal period, and that paper does also review the literature on antidepressants in pregnancy. And then there is a second paper on more severe conditions in pregnancy and postpartum, and a third paper on the effects of perinatal mental disorders on the fetus and child. And I will sometimes refer to those papers as I give this talk. Just to start, I wanted to just remind us that when we're thinking about medication in pregnancy, we also need to remember that mental illness in pregnancy is potentially devastating, both to the woman and potentially for the pregnancy. Of course, the woman is likely to be distressed, she may have poor self-care, she may not eat very well, it's likely to impact on her functioning, both at work and also at home with her family. If ill and severely ill, she may fail to access obstetric care. She may act impulsively and in a way that is not normal for her. And of course, we know that suicide is a significant contributor to maternal deaths, both in high-income countries, and a recent systematic review published by Vikram Patel's group demonstrate that this is also a significant contributor in low to middle income countries as well. Of course, if a woman is mentally ill during pregnancy, then that is going to affect her experience of childbearing. And we recently published a meta-synthesis of the qualitative literature to hear the women's voices about their experiences of pregnancy and the postpartum period. And of course, for them, as for other women, motherhood is central for their lives, but they are very aware of the potential stigma of their disorders. They feel very guilty about whether those disorders might impact on their child. They are very worried about the potential for custody loss and people making decisions based on diagnosis rather than their abilities to parent, and they can end up very isolated. We know also that illness is going to affect the fetus and the child in some cases. And as I mentioned earlier, our third paper looked at these relationships between maternal mental disorders and outcomes for pregnancy, for the infant and for the child. This includes a review on the literature of depression and its association with preterm birth and low birth weight, and other illnesses and other adverse outcomes. But what this paper and review makes clear is that adverse outcomes are much more likely in cases of socioeconomic deprivation. If a family is in conditions without adversity, then there is much less likely to be any impact on the child, and chronicity of disorders is also important. We also need to remember that it's not just about the illness, but also about other factors that may impact on outcomes, such as diet, smoking, substance misuse, genetic and epigenetic processes, and also, of course, paternal psychiatric disorder. So when thinking about the evidence between disorders, medication, and adverse outcomes for the fetus, we need to remember that there are many other factors that may be involved in these disorders. So what is the evidence on treatment of depression in pregnancy? Well, there's been limited evidence even on psychological interventions, but there have been some relatively small randomized controlled trials and clinical experience as well. Both suggest that psychological interventions can be effective for depression in pregnancy. I'm focusing on depression because that is the condition for which antidepressants are usually prescribed, but we do also review the other conditions in our evidence reviews. Of course, interventions need to be tailored for pregnancy. They need to consider the impact of the woman's disorder on her ability to bond with the unborn child, and also on some of the issues such as behavioural activation, which will need to be modified for pregnant women. Nevertheless, where possible, we would suggest that psychological interventions would be first line. However, for some women with more severe illnesses or a history of severe illnesses, they are much more likely to need medication. And the evidence base on medication is, of course, based not on randomised controlled trials because of ethical and logistical difficulties. It's based on observational studies. And increasingly, these observational studies are being pooled together into meta-analyses. The early data from these observational studies did suggest a number of increased risks and also quite significantly high levels of risk. But as the evidence base has improved in terms of quality, we find the risks to be much lower than was originally thought. And some studies, with particularly high quality, sophisticated new methods, actually don't find evidence of increased risks. So the evidence base is quite confusing. One thing that is helpful is that the quality of the evidence is improving. And this is partly because of our ability to link administrative data sets, sometimes using multi-country administrative data sets, and also using primary care databases. Nevertheless, the evidence is always limited by the problem of residual confounding. There will always be factors that have not been adjusted for in any of these complex, large observational studies. And one of the most complicated issues is confounding by indication, because often these data sets are not able to measure just how severe the illness was for which the medication is being used. There is, however, the potential now for clinical informatics using de-identified complete electronic health records with data on severity. And we have recently generated a cohort of women with severe mental illness in contact with secondary mental health care, showing that this can be done and actually allows us to establish data on some of the important confounders, including severity of illness, smoking, domestic violence, etc. We are also finding studies now using propensity scores, sibling control design, and as I mentioned, many of these studies are actually not finding associations. And we've recently discussed in an editorial in BMJ the use of some of these better quality designs and what they might mean for women's understanding of the evidence. The other issue of note is that most studies focus on risks. Very few actually give evidence on the benefits of medication. And of course, when one's thinking about whether or not to use a medication during pregnancy or outside of pregnancy, one needs information on the potential benefit as well as the potential harms. Any clinical decision requires appropriate individualised assessment, and that's not only going to be about the medication, but also about the severity of the illness potentially. What we do know is that for some women, there is a risk of relapse of depression if prophylactic medication is discontinued. So we are thinking here not only about treatment of acute illnesses, but also of maintenance medication. And if one looks at the two large studies, one in a tertiary referral centre by Lee Cohen, published several years ago, and another by Yonkers, published in a more community sample, what we find is that there is an increased risk in women who have a history of recurrent depressive episodes. This literature therefore suggests that antidepressants may not be needed for all women who are presenting with depression, by no means, but will be indicated for women who have a history of severe recurrent episodes and are likely to relapse if they discontinue medication. So what are the principles of using medication in pregnancy? Well, the first issue is to think about the possibility of pregnancy and, of course, breastfeeding in all women of childbearing age women who are being prescribed psychotropic medication. We know that many pregnancies are unplanned in the general population, and therefore, in somebody who may get pregnant, we need to be thinking about whether this medication would be appropriate during pregnancy and discuss this possibility of pregnancy with the women and discuss the evidence at that point. Therefore, drugs that are contraindicated during pregnancy really should be avoided in women of reproductive age, especially those for whom we know have very severe potential adverse outcomes, such as sodium valproate and carbamazepine. As I also mentioned earlier, where appropriate, one could use psychological interventions as first-line treatment. Therefore, the threshold for using pharmacological interventions will be different in pregnancy, and we would advise using psychological interventions as first-line wherever possible. Similarly, polypharmacy should be avoided wherever possible. But when somebody is pregnant and is then very worried about medication, what often happens is that primary care physicians and women themselves discontinue treatment very abruptly. And that, of course, is particularly likely to be associated with a higher risk of relapse, particularly in women with a more serious history. Continuing treatment actually might minimize fetal exposure because they may need less medication than if they became acutely ill. Switching, of course, is an option in pregnancy, but that might also mean risk of relapse, and one again needs to think again about the individual's history and what switching might mean for her risk of relapse. Whether using maintenance medication as prophylaxis or acute treatment, one should use the lowest effective dose. That does mean, however, effective as well as lowest. There is little point in reducing the dose of medication just to minimize exposure to the fetus, when that dose will actually be ineffective. If somebody is taking a medication during pregnancy, then we need to ensure adequate fetal screening and that the obstetric and neonatal teams are informed that this has been used during pregnancy. Risk-benefit decision-making with women does, of course, mean being up to date with evidence, including what is not known. And that is a challenge. And if one doesn't know the evidence, one really needs to ask somebody who does, rather than give a rather incomplete evidence base when you're talking about the evidence with an individual woman and her family. Of course, one needs a good therapeutic relationship when discussing these risks and benefits of medication. Capacity needs to be assessed to make sure a woman understands the information, and risks and benefits need to be individually discussed with each individual woman. That means that you need to choose a drug with the lowest risk profile for her and for her baby, but you need to take into account a woman's previous response to medication, and that might include actually having not done very well with medication in the past. We also need to discuss and understand a woman's wishes and values and those of her significant others, her partner and her family, and of course review decisions over time, because a woman may decide not to use medication at the beginning of pregnancy, symptoms may get worse, and one can then again discuss what is the best thing to do. I like this model that Kathy Wiesner published several years ago now, which looks at all the different aspects of the risk-benefit decision model that one needs to be thinking about. The physician, of course, needs a clear diagnostic formulation. If the diagnosis isn't right, then maybe we're thinking about medication inappropriately. Is this actually somebody that's had severe trauma in childhood and actually also has PTSD, which is the primary problem, and could be effectively treated with psychological interventions, for example? We also need to think as physicians, what are the treatment options? There are other somatic options. For example, light therapy has started to develop an evidence base, ECT for severe disorders. Psychotherapy, or of course no treatment, and potentially supportive psychotherapy might be an option for some, along with mobilizing social support and helping someone with mild symptoms. Then there is the model around likelihood of outcomes, and this needs to be thought about both in terms of side effects for the woman, fetal toxicity, potential physical malformations for some medication, whether there's likely to be subsequent neurobehavioral adverse outcomes, whether there's likely to be a neonatal toxicity, and also, of course, outcomes for the depression. What is likely to be the outcome for the treatment in terms of remission? And then, as I mentioned, values are really important here. Some women would be devastated if they had to take medication, and that actually could make their depression worse, whereas for others, they feel that medication has been helpful and they need it to stay well. One needs to think about the relative values for individual women. So thinking about the assessment, at NICE we were very concerned to make sure that assessment is comprehensive. One's thinking about the history and the family history, the physical well-being, alcohol and substance misuse, what is the woman's attitude and experience of the pregnancy, what is her relationship with the unborn child, has she had current or past treatment, what are her social networks like, what are her living conditions like, is she very isolated, is she experiencing domestic violence, is that actually the main problem that's leading to depressive symptoms, does she have a history of sexual abuse or trauma or childhood maltreatment such as neglect. What is her employment situation? Is that a source of stress? What is her financial situation? And is she concerned about her immigration status and that actually being a major factor in her depression? What are her other responsibilities? Does she have learning disabilities or other acquired cognitive impairments? And if so, make sure that you liaise with the relevant specialists. And then, of course, assessment also needs to include a risk assessment in terms of self-neglect or self-harm to her, and also risk to others. And of course, we all have local safeguarding protocols, and if there are safeguarding concerns, one would need to follow these. So assessment and diagnosis is crucial. If one's then thinking about different treatments and the benefits and risks of those treatments with a woman, we were keen to emphasise in NICE that the woman's central role in reaching a decision about her treatment needs to be acknowledged, and the professional's role is really to inform that decision, to give her balanced and up-to-date information and advice that is relevant for her. When giving advice, we need to use absolute values based on a common denominator, rather than giving relative risks. Absolute risks are much clearer to a woman than relative risks. We also need to acknowledge and describe the uncertainty around estimates of risk and harm, and of course of benefit, and where available use high-quality decision aids, some of which are currently being developed, and consider providing records of the consultation. In our practice, we usually give a letter detailing the complete discussion of all of the risks and benefits that we had discussed during the meeting that we had earlier. So we have gone into some detail about the type of discussions that mental health professionals need to have when they're discussing mental health problems and treatment in pregnancy and the postnatal period, and of course, as I mentioned earlier, if planning a pregnancy. So not only uncertainty about the treatment risks and benefits, but also the benefits of treatment in line with her previous response, the background risk of harm. There is no such thing as a risk-free pregnancy. There will always be some risk of a malformation or other problems, and that the risk may also be associated with no treatment, because a woman's depression may mean that she's not eating well, and that might affect, for example, the growth of the fetus. So one needs to discuss the risks or harms to the woman and the fetus associated with each option, and also the possibility of exacerbation or sudden onset of mental health symptoms. For example, in a woman that's previously had a postpartum illness, there might be a risk in the first few weeks after childbirth. One also needs to discuss the need for prompt treatment because of the potential effect of an untreated mental health problem to the fetus or baby, and that stopping treatment or changing treatment can also be associated with risks or harms. So if a pregnant woman has taken a psychotropic drug with a known risk at any time, then pregnancy needs to be confirmed as quickly as possible. The risks of stopping or switching needs to be discussed. It is likely that stopping or switching will not remove the risk once a woman is pregnant. And screening needs to be offered for fetal abnormalities, counselling about continuing the pregnancy, and explanations around the need for additional monitoring. So really, ideally, we want to start treatment having had the discussions about the higher threshold for starting psychotropic drugs, about the risk benefits, before a woman actually finds that she's got an issue around a medication having already started a pregnancy. One also needs to be aware that there might be some drugs one doesn't have much experience with, so one needs to seek advice from a specialist, and also to, again, take account of that latest evidence. And I just wanted to remind you with this slide that every week there is a new study being published about the potential risk of a particular antidepressant and a particular outcome. In fact, only this morning before I left my home, yet another study had been published, and I had an email alert about a study that did find an abnormality associated with antidepressants. However, taking evidence from single studies is not helpful. One really does need to look at the whole body of the evidence. And if one looks at the recent meta-analyses, one finds much lower risks than are sometimes found in individual biased studies. So currently, first trimester exposure has been associated with an increased rate of cardiovascular defects for some SSRIs. Much of this clearly is the effect of confounders, such as smoking, but a recent meta-analysis did find a small increased risk. Whether that is a real risk is still uncertain. It is likely to be the effect of confounders, but we do not absolutely know that. Turning to other potential adverse outcomes, poor neonatal adaptation, slightly jittery infants. In the majority, these types of syndromes are mild and self-limiting, but there is stronger evidence and more consistent evidence that this poor neonatal adaptation does occur, and women therefore need to be informed of this. And of course, it is less likely, it seems, for some drugs in women who go on to breastfeed. We also find that there has been an increasing interest recently in studies looking at the association between persistent pulmonary hypertension of the newborn and antidepressants. Again, we need to look at meta-analyses, and the latest meta-analysis found a pooled odds ratio of 2.5. What we know that means is actually in terms of absolute risk, because this is a rare disorder, we are talking around 3 per 1,000 deliveries. Again, though, none of those studies were able to fully adjust for confounding, and no study has found severe persistent pulmonary hypertension of the newborn associated with an SSRI, which is reassuring. And the level of this absolute risk difference is actually the same as the risk of obesity and persistent pulmonary hypertension of the newborn, which helps us think about the size of these risks. There's been some literature also on fetal weight gain and prematurity, and these again appear to be partly related to confounders such as smoking, partly due to depression itself, and overall, if there are differences, they are again very small. Of course, what many of us really need to know is the long-term outcome. And what many of us feel frustrated by the current literature is the very limited data on long-term outcomes, behavioural outcomes for these children who were exposed in utero. Again, the few studies that do exist have a major problem in controlling for confounders, including confounding by indication. And confounding by indication is particularly relevant in terms of long-term follow-up. I wanted to give the example of autism here. There were 2 recent nested case control studies on autism which did suggest a small increase in risk, whereas a large cohort study using Danish register data published in New England Journal with a much larger study population didn't find a significantly increased risk, and interestingly did find that women who received SSRIs before pregnancy but not during pregnancy did have an increased risk of autism spectrum disorders, suggesting that it may be something about the depression that was associated with the autism rather than the antidepressant. We also need to be aware that there is some evidence of positive outcomes being associated with antenatal use of SSRIs. These are small studies, but remind us that we need to be thinking about the comprehensive risk-benefit analysis. What is going to happen to women if actually their depression is treated? Might this actually improve outcomes for the infants? Sadly, we don't have any randomised controlled data in pregnancy in terms of benefits for women, despite the use of antidepressants in pregnancy. We do only have very little literature actually on antidepressants for postnatal depression, but there are at least some studies in this area and they do suggest benefit. And there is no reason to think that antidepressants would not be of benefit in pregnancy. So to conclude, women need high quality information on the risks and benefits of antidepressants in pregnancy to help them make decisions which will lead to the best outcomes for their individual situation. We still need more research on the benefits of risks of antidepressants for both maternal and child outcomes in pregnancy and also breastfeeding, an area that I haven't had time to touch on today. In practice, though, for some women with the more severe illnesses, antidepressants are clearly indicated, and women need to be supported in making decisions that are right for them and their families. Thank you.